Okay, then let everyone in.
So
Share screen.
we don't have to let everyone in.
Where's that
Okay,
little ball
recording.
guy?
Gotcha.
Where's that ball?
He's gonna-
So you are recording. I am, and then you'll share your, oh, Dee Dee, did you check his screen share? Or you should be good to go, Rees, you think?
I
Or-
think I should be fine, yeah.
Okay. So we are delighted to have Rees Cosgrove with us this morning. I think many people on the line know Rees in that he's right across the street now, but he grew up in Canada. I think I've seen a picture of you, Rees, because your dad was a neurologist at the MNI. I think I've seen a picture of you pushing stretchers
Yep.
as a teenager as one of your first jobs in the MNI. But he was trained in Canada, and when he finished his training, there's a couple of different versions of the story, but he was going to come to Boston to do a vascular fellowship with Roberto Heroes, but apparently the residents at the MGH had a little bit of a coup. He claims I led it. I don't think that's really true. But anyway, he ended up here at Beth Israel for 4 years as junior when he started his junior staffship, and then moved to Charlottesville and came back to Boston. Worked at MGH. I had the pleasure of having a locker 2 down from him in the locker room. So we became fast and good friends at MGH for a number of years before he went to Leahy and then down to Brown to run the program. And now back in town running the movement disorders, and going to talk to us today about his foray and his journey with movement disorders and how that's evolved over time. So Rees, it's a real pleasure to have you. I know lots of people online are your personal friends, and professional colleagues. So it's just great to have you here.
Great. So, well, thank you, Chris, and thank you, Ron, for allowing me to speak to you today. Dee Dee, you have to unshare you've disabled the host, the share screen. So I'm going to see if I can share mine. It says host disabled participant screen sharing. So whatever you need to do.
I think it said we're screen sharing.
You're screen sharing.
Yeah.
But thank you, if you guys can figure that out.
Okay.
Once I had to give a talk at Beth Israel with no slides back in the 90s, and it was an interesting experience. It was to a bunch of neurologists and psychiatrists, but for neurosurgeons love to see pictures, so it would be good if we could get these activated. But you know, it's so appropriate to when I was making this talk up, you cannot start screen share while the other participant is sharing. So you have to unshare, okay?
Yeah.
And voila, okay.
Okay.
Can you see that now?
Yeah.
Beautiful.
Yes, you are good to go.
There we go. Okay. So, you know, it was fun making up this talk because it's so poignant that I'm giving it to you guys at Beth Israel, because this is where, you know, in 1986, this is where I cut my neurosurgical teeth as a young attending fresh out of residency. And what I thought I'd do today is just tell you my story in my own personal story in movement disorder surgery. And like any personal story, it has its own biases and perspective. So I may say some things that may appear frankly heretical, at least to Ron, I think. But you know, we're all formed by our experience. And this is just my experience in movement disorder surgery. So here's the obligatory conflicts of interest. Part of what I'll talk about at the end is focused ultrasound. And I do have received research funding for a bunch of clinical trials from them. But my true confession, and I'm making this public, is that I still really love the stereotactic frame. I think it's one of the most versatile pieces of equipment in neurosurgery. And sadly, in this day and age, it's almost hardly ever used anymore by residents. But so there's my first clear bias. But you know what's interesting is my training in movement disorder surgery was really at the foot of this man, Gilles Bertrand, who was just a master functional neurosurgeon. And in fact, it goes back even earlier, because before I was an orderly at the Montreal Neurological Institute, when I was a high school student at age 15 and unemployable, at least unemployable in terms of getting paid to do anything, I worked in Dr. Bertrand's lab in the summer and got a little stipend, I think of a couple of $100 for working the 2 months there. And I created a database of some of his 1,400 stereotactic procedures. So at a very early age, I was sort of weaned on ventriculograms and x-rays and stereotaxy when I hardly even knew what it meant. But I learned my movement disorder surgery from, at least initially, from this man, and he was just a complete master. And you have to understand, it seems, and this was 40 years ago, in the early 80s where we were doing this, we did it with ventriculograms and plain x-rays. And you would drill a hole, cannulate the lateral ventricle, pour some dye in, get it to go through the foramen Monroe, outline the third ventricle, and then you'd get the films out, and you'd get your protractor and rulers and scratch on. You'd find the PC, you'd find the AC, and we do both a lateral and an AP X-ray, and we do all of our targeting on a ventriculogram and plain skull X-rays. So this is how all of these surgeries were done in the past, and this is how I learned how to do this. But the younger members of the audience would say, well, how do you target anything from this? Well, the way stereotaxy evolved in the 50s and 60s was based upon stereotactic atlases. And there's a whole huge number of atlases available. The Bible, and the one we used, was the Schulten, Brandon, Warren Atlas. And basically it's based upon 3 brains, human brains, that were cut in, one brain was cut in axial sections, one in sagittal sections, and one in coronal sections. And they were all based upon this ACPC line and the mid ACPC point. So that's why stereotactic atlases are always in relationship to the mid ACPC point, because it was only the ACPC that we could reliably see on x-rays and the ventriculogram. So everything was calculated from that point. So what you would do, you had this big atlas, and you would find the target that you're interested in, and find the coordinates from that mid ACPC point. So for example, in this, you would take, if this slice, you take a coronal slice 2 to 3 millimeters behind the mid ACPC point, and you turn to that page, and there you would see these are 1 centimeter markings, with this being the midline and this being the ACPC plane. And you can see here that if that's the midline, it's a little further over, but this is 10 millimeters. So the posterolateral portion of the subthalamic nucleus is about 11 or 12 millimeters lateral, and about 4 millimeters below the intercommissural plane. And so this was our preliminary target. That's how we found our targets in the days before MR stereotaxy. And so that is how all movement disorder surgery was carried out. And now, being a neurosurgical resident, we didn't explore the subthalamic nucleus. We always did just thalamotomies in those days. And so that would be a different coordinate. and a different slice of the atlas, but that's how we would target. And then we would have to explore to confirm it, because this was a single person's brain and everybody's brains are slightly different. But targets close to the target in the thalamus, closest to your commissural line and points, are more accurate than targets farther laterally. But this is how I was trained to do thalamotomies. And what's so interesting is I think I performed my first solo thalamotomy at the Beth Israel in 1988. I remember doing it on a patient with severe post-MS tremor. And at that point, I didn't do it with ventriculograms. I did it with just CT scans and calculated off a CT with a stereotactic frame. So when I was in Charlottesville, and in 1992, Laurie Leitinen and Marwan Hariz re-energized and refocused and reintroduced Lexell's posteral ventrolateral pallidotomy for Parkinson's disease. And this was a remarkable paper because they re-energized Lexell's surgical experience and produced this paper that got me very interested in pallidotomy. And so when I came back to the general in 1992, I started performing pallidotomies. And I performed probably about 150 of them there. And we reported this series of, now this was non-microelectro-guided pallidotomies. And it was a remarkably effective operation. So this, and how I did these was, again, at this point in time, now we had, I did these with both MR and CT stereotaxy, and I would target the GPI, and I would place my electrode with a trajectory down into the ventral portion of GPI, and I would just use macro stimulation. So this is just through the lesioning electrode you can stimulate, and we'd look for motor thresholds, sensory thresholds, and symptom resolution at higher frequency, and that could tell me where I was in relationship to the optic tract and the internal capsule. And when we would, then I would make the first lesion at the base, which was the most dangerous one because it was closest to the capsule and closest to the optic tract. And then I'd withdraw the electrode and make another lesion 2 millimeters in size, and a third one, another 2 millimeters in size, to create a lesion that was about 6 millimeters in size in the pallidum. And this is what the immediate post-op MR would look like. And you can see the lesion is the dark area, and then you see this ring of edema around the outside. And it was a remarkably effective operation. It was really truly revolutionary. And at that time, I was working with Jack Penny and Leslie Shanubu at the General, and they didn't believe that this was going to be a good operation, and they became complete converts to it because they never had so many patients come and, as neurologists, come and thank them for convincing them to have this operation. And when you look at the results of this, you know, UPDRS scores and ADL and motor scores were dramatically improved postoperatively. The off times were dramatically improved. It basically abolished dyskinesias contralateral to the surgical site. And at least in our experience, and this wasn't true with everybody doing pallidotomies at the time, we got a remarkable improvement in tremor. So this was sort of the state of the art in the early 90s and the mid 90s. And at the same time, Benabid had introduced the concept of stimulation, deep brain stimulation. So original paper was in '87, but it really didn't hit the mainstream until the mid-'90s. And he was basically taking, had the brilliant idea that of everybody who was doing this kind of surgery, that when we were on target, one of the ways we confirmed that we were on target was if you stimulated through the lesioning electrode at high frequency, you'd get a physiologic ablation effect that was just temporary. So his genius was saying, well, this was an observation that all movement disorders neurosurgeons had, that if you stimulated high frequency, you could create a physiologic ablation that was temporary. And his genius was, well, why don't we create electrodes that permanently implanted that can do the same thing? And then he teamed up with Medtronic, and that's why Medtronic was the leader in DBS for so many years. And the beauty is that you could routinely place it bilaterally. So because bilateral thalamotomies at the time were associated with a fairly high incidence of complications, severe complications, including severe dysarthria and even cognitive and disturbances. This was a revolution in movement disorder surgery. And for basically the next 20 years, this was the gold standard and continues to be, I think, the gold standard. And, you know, I think about 300,000 people have been implanted with DBS electrodes throughout the world. So it really is a very dependable and familiar technology to all of us, both surgeons and movement disorder neurologists. And this is what this was the technique that we used, and I think is used throughout the world, and it allowed us to go into this risky target of the subthalamic nucleus. And we would, you know, of course, do this surgery awake. We'd have to take the patients off their Parkinson's disease medicines to see the hyperactivity in the subthalamic nucleus. And we had to use microelectrode recordings in at least the subthalamic nucleus, and I converted to those. Although I'm not a trained neurophysiologist, so my sensitivity and my sophistication in microelectrode recordings was more limited. At the time, however, my resident was Ahmad Eskandar, and so we teamed up to do this at the General, and you know, this is patient awake.
Or one of the pins is?
You know, you're talking to the patient. And the idea is, at least from my perspective, was we would look for the longest trajectory through the subthalamic nucleus.
Typically, it's thought to be thalamic border cells, part of the laminar nuclei. Yeah, it sounds like a motorboat. This one really sounds like a motorboat. Yeah.
And there's the subthalamic nucleus. So there's the subthalamic nucleus, a very stereotyped electrophysiologic signature. And my level of sophistication was that when the electrode went through the bottom of the subthalamic nucleus, it started looking like this. So you could define, you could make adjustments to the outline, the border of the, you could make define the borders of the subthalamic nucleus. And you know, the subthalamic nucleus is a small, very small target. So each of, as we went down through the thalamus and through the zona incerta and then into the subthalamic nucleus, you got a intraoperative confirmation, and we're able to adjust sometimes because your initial targeting may have been off. Because here's the thing. In all of these procedures, when we're doing it this way, you put a stereotactic frame on, then you imaged CT and MR or some fusion or whatever technique you used, but you targeted on a closed cranium, but you were operating on an open cranium. And so when you open up the head on both sides, you know, CSS comes out, air goes in, and the brain can shift. So you needed some way to confirm that you were in the right place. So this was exactly how we needed to do this. And this is how I did it for many years. In 2004, Phil Starr and Paul Larson, Phil Starr was a resident here and actually spent time with me at the General as a fellow. They came up with the idea of maybe doing some DBS asleep in the MRI. And I thought this was a stupid idea because I was very happy doing it the way I'd always done it. But when I came to the Brigham in late 2015, they had this Amigo suite, which is a $25 million operating room with every neurosurgical toy you could possibly imagine. It has, biplane fluoroscopy. It has a 3T MRI that can move in and out of the operating room. It has a PET CT on the other side of it. It has everything. And I thought, I call it the surgical expensive care unit because it's ridiculously expensive and with the people all around it. But when I said, well, if there's anybody who should try sleep DBS, it's probably me and I'll see if it's really valuable. So I started doing this when I came to the Brigham, and it has certain advantages. I mean, there are some patients who just really can't tolerate being awake, but it requires doing it in a less friendly surgical environment. And the positioning system was this molded plastic device called the ClearPoint system, which I thought was the stupidest thing I'd ever seen. I love a rigid a stereotactic frame. This was molded, extruded plastic. And I said, you can't do functional stereotaxy with an extruded plastic frame. Turns out I was wrong, because this is the system I use. And basically it's a fancy burr hole mounted device. Here you see the operating setup. The patient's placed in the MRI scanner. I'd make a bicoronal incision with 2 burr holes. And you do all that work with the patient's head out the end of the scanner. So we have all MR compatible equipment. And then you place each of these ClearPoint devices over each burr hole. And then once that, and the dura is open and all of the shift has occurred. So basically we haven't targeted yet. You can see the 2 devices here, one on each side. And so the cranium is open, air has leaked in, CSF has leaked out, air has gone in, and the brain is now in a stable position. And then the patient goes into the scanner and they're way in. They're right in the center of the scanner. And we have these long straws that come out through the top with these colored rims on it, which allow us to adjust the trajectories. So, and then once the patient's there and ready to go, actually that's the moment we target. So, and the targets we start with are standard stereotactic atlas-based coordinates, but then, and I mean, these are all anatomical areas that we're all familiar with, but then we target using, for GPI, we use an F Gator sequence and a T2 sequence. And if you look here, you can actually see, here's the putamen, here's GPE, and here's GPI. And if you look really carefully, you can actually see the accessory lamina inside GPI. So it's no longer just, so we start with the atlas-based coordinates and we adjust because all patients' brains aren't the same, especially in GPI in terms of the lateral dimension. So it's not indirect targeting and atlas-based targeting anymore. it's actually individually adjusted targeting in the shifted brain. And it was always hard to see STN, but we use T2 and SWI images, and it's just, you just see the target now. You see the nuclei now. So it's not a matter of trying to confirm it indirectly with electrophysiologic recordings. You actually see it, which for a simple neurosurgeon like myself, that's really good, because DBS is based upon accuracy of the location of the electrode. If you're not on target, it's not going to work very well. So, this is how we target, and then we use this system to. So this is, if we by dead reckoning, it shows us where the target is pointed, and then it gives us these little corrections. The computer system says, okay, turn this knob for the pitch, turn this knob for the roll, you adjust it, plunk, you get it pretty close, and then there's a little X and Y axis on the system, and you make your fine adjustments with 2 dimensions, X and Y, and once it's perfectly lined up, then you're ready to place your electrode. So at that point, we bring the patient out of the scanner, everything is perfectly lined up, and then you place, we first place a ceramic stylet so that it doesn't interfere with our imaging, and these are the images you get. So you actually see the electrode in place intraoperatively, you confirm it intraoperatively. And it is really, I think it's not indirect confirmation that you're in the right spot, it's direct confirmation. So I've really become a believer in this way of doing it. And we've done about 135 of these now, but we've looked at the very first, these are from the very first case where I was a complete beginner with this technique to over 100 cases. And again, I do 2 of these every second Monday when I get time in the magnet. Every single electrode was inserted on the first pass. And I'm pretty good at doing this because I've done it a long time, 40 years, movement disorder surgery. But amazingly, the accuracy, the radial accuracy was 0.54 millimeters on average, which is highly accurate, highly consistent. And basically the patients, the procedure takes about 4 hours. They stay overnight and go home the next day. This is a clinical series, so we don't have, off UPDRS scores and, all on that. But my 3 movement disorder neurologists have really confirmed that they get fantastic results. In the 100 and so patients that we've done, even in the last 5 years, I've only had to replace 3 or 4 batteries. That's not a great demonstration of efficacy, but it does suggest that the targeting is very accurate. Complications, you can't stick things through people's brains without complications. The 2 major complications of DBS are obviously hemorrhage and infection. We've had 2 infections. One of the criticisms of operating in an MR environment is that you increase the risk of infection. We've had 2 infections. I do this not in the MR environment. I do this as a second stage, as an outpatient, putting in the battery and the cables. So we've had 1 infection within the first 6 weeks, and I had a second infection over a year out in a diabetic patient. So we had this patient who had had electrodes placed the old-fashioned way with microelectrode recordings for tremor. And 1 was clearly off by about 4 millimeters. And we had to remove all the electrodes. I removed it under general anesthesia and replaced them. And this woman had 2 hemorrhages where I think the trajectories crossed in the head of the caudate, and completely asymptomatic, and had perfect tremor control now because both electrodes are in a better location. And you wouldn't have known this unless you had this intraoperative imaging, or you would see it on a post-op CT, but you see any complications in the MRI scan. And we had one woman, an older woman, with a venous infarction on the surface, a small venous infarction due to some delayed occlusion draining vein. And she was symptomatic for several days to several weeks afterwards, but this also cleared. So again, these are the sort of the expected complications you see, but I think at a lesser rate than published series. So I've come to believe in this. It's certainly, many patients prefer it. You get perfect blood pressure control. They can take their medicines right up to the surgery. So they don't have to be off medicines for the procedure. The real beauty, the real value in this is that we do all of our targeting once the cranium is open. There's no fusion technique. There's no inaccuracies introduced by that. There's no inaccuracies based upon a shifted brain. And remarkably, I make a single penetration. So with just the ceramic stylet. And so I think there is definitely a reduced risk of hemorrhage. So basically, if it's intraoperative MRI targeting and intraoperative confirmation, what you see is what you get. So I've really become very, I think this is a great way of doing it, at least in my hands. So let's shift a little bit. What time is it? Yeah, let's shift a little bit and talk about, I think everybody's familiar with this New England Journal of Medicine paper. When I came back to the Brigham, I was fortunate to get involved in the focused ultrasound trial. This was a randomized, sham-controlled, blinded assessment of a novel surgical intervention. And what's interesting is almost no operations we do as neurosurgeons have ever been put to this kind of test. We do all sorts of operations that have never had randomized, sham-controlled, blinded assessments. But this was there were 8 centers, 8 different neurosurgeons, many of whom had never performed a radiofrequency thalamotomy, using a technology that they had never used before. And I was convinced that if the technology worked and could do what it said it would do, that this would be a very successful trial. And indeed it was. If you look at the results of that trial itself, clearly the patients who had the frame put on, head shaved, frame put on, put in the magnet, but didn't get lesioned, their tremor didn't change, and the outcome assessment was at the 3 months. And the ones who did get treated had a clear-cut improvement in their tremor. What's interesting is that the patients who were shammed, they got treated after the 3-month follow-up, and this is the light blue bar. Those patients did a little better than the initial ones, probably because the surgeons and the team involved had more experience with this technology. And so the primary outcome measure was tremor control in the treated arm, and that met significance of more than a 50% improvement. Disability scores improved across the group, and of course quality of life scores improved across the group. So a very definitive, declarative trial. And this allowed the FDA to approve it for essential tremor in 2017. So, what's involved here? Basically, there are 1,000 tiny little ultrasonic emitters embedded in this helmet. It looks like a fancy hairdryer that's mounted on the MRI table, and it's all done inside the MRI scan. And I'll show you this. It's sort of, I think, good for people. This is an educational video that we do for our patients to sort of make them aware of what they're about to go through. So this is a patient in the prep area outside the MRI suite. He's a 76-year-old guy with bilateral tremor, worse on the right. You can see he's having trouble. He can't write. He has real hard time feeding himself. He can't drink from a cup without a cover and a straw. And he's trying to write his name by steadying his hand a little bit. So you do have to shave the whole head. And I'm not talking just a clip. I'm talking you shave it like as smooth as a baby's bottom. And then beauty is we get to attach a stereotactic frame. It has to be really low to keep as much as the cranium exposed. They basically walk into the MRI scan, sit down on the table. We place a waterproof membrane over the top of the frame, because when they're put into the helmet, this membrane mates to the helmet, and then the space in between fills up with water, okay? You can see it filling up. And so then they go into the scanner, and that we image for about 45 minutes. So they're just lying in the scanner, we're imaging, they're in there for 45 minutes, we're doing all our imaging, we're aligning everything. There's a bunch of stuff that we do. And then before we've done anything, before we've done anything, I take them out I bring them out of the
Holy Roman Catholic Church.
So then I do a baseline neurologic assessment. So I'm testing his speech. We're seeing his tremor, seeing his fine motor activity and strength, testing sensation. Okay.
Here, pretend you're going to drink from that.
So and then we have him draw so now he has to grab the pen, so we're testing for dysmetria.
See that spiral start in the center, stay in between the black lines.
So I'm asking him to sort of draw his spiral. You can see he's having, it's almost impossible for him to do this. So I'm helping him out to see what he can do. So this is,
Try and draw a straight line from there across.
this is what we, so this is before we've done anything. We've just taken MR pictures. So this is his baseline. So I want to know exactly what he looks like prior to us doing anything. We put him back in the MRI scan. I do a couple of alignment shots, and then I do a treatment. I make a lesion that's 2 to 3 millimeters in size on my target. Boom. And then I gradually enlarge it. They go back and forth, back and forth.
Here comes the second treatment.
It's an iterative process. We see the lesion being made as we make it, which is amazing. So while we're doing the sonications, we're actually doing MR thermometry as we're treating. We see the lesion developing. We see the heat arise, and there you see this absolutely perfect tremor control. So we get tremor control in everybody on the table. And then we we test again for strength, sensation. So then we release them. They walk out of the MRI scan, take the frame off. We just see them,
Point your fingers.
and it's not surprising to me, because So here's the drawing before we did anything. Here's after the second treatment. So it's not surprising to me because it's a thalamotomy. It's just new technology doing an old and trusted operation. The targeting is done basically the old-fashioned way with an AC-PC coordinates. I just use a quarter of the length in front of PC and about 14 millimeters lateral, and I make some adjustments based upon the patient's individual anatomy. And we can do test lesions at 42 degrees to check to see if it's if there's any side effects. But I've gotten so confident you know, with the targeting that we make the lesion in steps, iterative steps, 2 to 3 millimeters at the beginning, and then gradually enlarge it to 6 to 8 millimeters in size for the permanent effect. So that's how we do it. And as I said, we see the lesion being made as we make it, which is remarkable. So patients in the scanner, we're treating them, and we see the heat maps develop as we're doing it. The sonications take 15 to 20 seconds. They're very short. The patients do have some discomfort from it when they're doing it, but, and then, so here's an example of, you know, somebody's drawing and trying to do a spiral, do a straight line, and write their name. Here's after the second treatment, much better. Here's after the third or fourth treatment. Again, as good as you could ask for. So it's an immediate effect. Early on, I said, well, I wonder what this looks like. So early on, the first couple of patients, immediately after doing the treatment, I took the frame off their head, put them right back in the MRI scanner, and did a T2 image. And so this is what it looks like 20 minutes after we finished the procedure. You can see it's just above subthalamic nucleus and roughly on the plane of the red nucleus. It's exactly where, and just medial to the internal capsule, exactly where we'd want it. This is what it looks like the day afterwards. So it's swollen. It's 24 hours later. It looks much bigger, and you can see the lesion itself has expanded, and you see this rim of edema around the outside. Remarkably, on the right, this is what it looks like 3 months later in almost everybody. It's almost impossible to see the lesion, which is very different than radiofrequency. We always see a hole with radiofrequency. This, you can't see it. If you do SWI, and in fact, if you look very closely, there's a little darkness right here. Little darkness, but remarkably, there's no hole. And it doesn't, this is seen basically in everybody. Tremor control doesn't change. Tremor is still improved. And that was remarkable to me. So there's something about ultrasonic heating that is different than radiofrequency heating. We've done about 155 patients, but we've reviewed the first 123. And what's interesting is this is not this is a procedure for people that don't qualify for DBS. So our mean age is 75. And I have a couple of patients over 90 that I've done this on. Most of them have ET, as you might expect, but and there's a male predominance. But so this is for people who don't really older people that we would think might be too much at risk for, or who just say, I don't want to have implanted electrodes. In the first little cohort, we did exhaustive, complete CRST scores and tremor scores, and out to a year. And even when these lesions disappear, as you can see on the bottom slide, the tremor is sustained out to a year and beyond. We have 2-year follow-up on these people, and it just stays improved. On the entire group, which we don't have complete CRST scores on, but we do have tremor scores on the affected hand, again, you can see a dramatic improvement in their tremor. We get basically tremor abolition on the table in everybody, and it's nearly completely abolished in 2/3 of patients at 1 year. So it's very effective at tremor control in the hand. Has complications. Almost everybody has some side effect. And this is because it's still, even though it's non-invasive, it's still surgery on the brain. So, and almost everybody experiences some sensation of imbalance. So at least almost 2/3 of people feel a little off balance. And that can persist, especially in old, frail people who have a bad balance problem and to begin with. So I've stopped doing those patients. Many people will have a little paresthesia on the lower lip, which gets less and less, but and is not a serious side effect. That may be just due to my targeting, but patients don't even report it unless you ask them. There's an interesting side effect of dysgeusia, so alteration of taste. And we've had a few instances of weakness. And the weakness always occurs because of you see here on this image, there's a tail that goes in, that sometimes, this is not just a round sphere that we make, it's an oblong, it's an ellipse, the lesion we make. And we've seen these in people that are harder to do with thick skulls, and we have to turn the energy up. And so the more energy you use and the longer you have to use it to create heat, you get a distortion of this tail, and you can see this little tail going into the capsule. And in the patients who this tail has gone into the capsule, which, as we all might expect, these are the people that will have some dysarthria, which always clears, but we've seen 2 or 3 patients who've had fairly pronounced hemiparesis, isolated typically, either in the leg or the arm or the face, and then but it can take a long time to get better. And the other way that we see side effects is when the lesion is way too big. And so here you see this is too big a lesion. It does not encroach upon the capsule, but it was too big. This person had some dysarthria, which actually cleared, but also it extended too far back and had some paresthesias, permanent, both in the lip and the fingers. So, but remarkably, almost all of these they're all mild, and they all improve over time, much as a lacune in the brain would. So, we know what the target is. It's VIM, and if we just place a small lesion right in the target, you'd get initial tremor control, but the tremor would return, but no side effects. If you do it just right, you get good tremor control, no side effects. And if you make a lesion that's too big, obviously you get great tremor control, but you have side effects. So it's the Goldilocks dilemma, not too big, not too small, just right. And so in thalamotomy, at least focused ultrasound thalamotomy, size does matter. Some of the things we're doing differently now to remarkably, we're starting to look at MR, the nuclei. We can begin to parcellate out the different nuclei in the thalamus. It's remarkable. There's a new white matter null sequence. It's like an F Gator sequence on steroids, and you can actually start seeing the different nuclei, which is something we talked about 20 years ago when I was at the General. Would we be able to do this? And so that's what we're doing now. And the other thing that's fascinating is that even on these funny MR thermometry images, we can make out anatomy. So here's what you can see here on the left. This is the raw image as we're doing it in the MRI scanner, and on the right is it's registered to the post-op scan. But you can actually see the capsule. You can see the red, the shine through of the red nucleus, and this allows us to adjust our targeting as in between shots. So we actually are able to do some adjustments in the scanner while we're doing the procedure, in addition to making adjustments based upon the patient's clinical exam. So it's really been a remarkable journey. You know, we've gone from frame-based to frameless movement disorder surgery, gone from awake to asleep, and now back to awake with at least focused ultrasound. I think the difference for me has been, you know, we used to do all of our imaging and targeting preoperatively. Now we do it intraoperatively. That's a huge advance. We've gone from indirect targeting to direct targeting, and I think the next step will be to connectivity targeting with DTI and these nuclear maps. I'm a little leery that it's going to make it too easy for people, but we've gone from indirect confirmation with microelectrode recordings and macro stimulation to intraoperative confirmation of our targeting. We've gone from ablation in the 50s, 60s, 70s, and 80s to DBS in the 90s and the 2000s, now back to ablation with focused ultrasound. And we've gone from minimally invasive to completely non-invasive with focused ultrasound. And remarkably, you know, focused ultrasound is an outpatient treatment. I do 2 or 3 of these every Tuesday. It's been you know, from being a young resident in Montreal in the early 80s, seeing, you know, a whole day procedure with ventriculograms, and it was a remarkable at that time when you see somebody stop shaking in an operating room, to today, 40 years later, there's been a remarkable evolution. And I've been very fortunate to have been witness to it. Anyway, that's it. Happy to take questions or discussion.
Rees, thanks very much. That was an excellent run through. I'll ask Ron Altman if he has comments or questions, or anyone else if they like.
Why would Ron have any comments or questions?
Okay. Rees, I had a question. This is Ajit Thomas here.
Yeah.
I just wanted to ask you, so are there going to be like machine learning programs where, you know, you may not have to do this yourself and you just fix the electrode and the algorithm figures out how to get to the target?
Well, that's above my level of education or expertise, Ajit. But yeah, the smarter people than me are already working on that. Certainly that's being started for the programming. You know, progress is exponential. So I'm sure these things will be applied in the future.
Anyway, thank you, Rees. Nice overview.
Yeah, thank you.
Wonderful work.
I know you're not a believer in the focused ultrasound or the asleep, Ron, and I get it.
We do a sleep DBS all the time.
Oh,
we just don't do it in the MR scanner.
Yeah.
So I do it Queen Square style. The use of the doing it with the frame in this with the asleep patient allows us, without muscle blockade, to still do at least motor testing of stimulation. And if you go back and look at Casey Halpern's meta-analysis, one of the issues was that there was an increased revision rate in asleep DBS, at least into the published literature, and it was mostly due to motor side effects of stimulation.
Yeah, I think you have to be, that's a targeting issue. I have never had to replace an electrode. And, you know, maybe it has to do with a fair amount of experience going into it, you know, before using the asleep technology. But, you know, you still have to target accurately.
Mhm.
If you're too lateral in your thalamus, or you're going to get capsular
Yep.
stimulation. And it's interesting, the targeting for the thalamus, Ron, is different, because when we would do a radiofrequency thalamotomy, or when you're positioning an electrode, I'm sure you position your electrode, the tip of your electrode, just below the intercommissural plane for the thalamus.
Mhm.
Well, that's not how we do it with with focused ultrasound. That's how I would do it with a radiofrequency electrode, because then I would make, 1 or 2 lesions. I'd start at the bottom and move up. The focused ultrasound is like the gamma knife. The heat is at the center and it expands peripherally. So
Mhm.
I always target 2 millimeters above the intercommissural plane. So if I make a 6 millimeter lesion, it extends just down 1 millimeter below the intercommissural plane. So you have to target differently. It's not that,
Mhm.
so there are subtleties to this that are important to understand.
Sure.
Rees, since you're from MNI, is this going to be an option for medial temporal lobe epilepsy also?
Yes, it's already started. The beauty of this focused ultrasound is that there are other ways of lesioning the brain. We have a low frequency device for opening up blood-brain barrier for tumors. You can actually do histotripsy with focused ultrasound and microbubbles to ablate. It's a little harder. The treatment volume that's effective is actually in the center of the cranium for this first version of the focused ultrasound device. It's hard to get more lateral and get heat, but they're working on other methods to actually be able to do that. And this, once that gets to that point, it's going to replace laser ablation of the mesial temporal lobe.
Can I ask a question of Dr. Cosgrove, please?
Yes, Dan.
Dan Tarsi. Just the concern about the 1 and 2 year follow-ups, at least you have 1 year follow-up on your slide, of the weakness, 5% I think it was, and gait disturbance you were a little bit concerned about. You don't do patients who come into this with gait disorder. Do you have any more quantitative assessment or functional assessment? Just how much of a deficit is this for patients? Is this something that is just giving them a new problem, or is it just a relatively minor sort of thing?
In the majority, Dan, it's minor. That the gait, the imbalance is a subjective thing. They'll say, almost everybody has a subjective feeling that they're a little off balance immediately afterwards, or at least 2/3 do. That tends to clear in a few days to a few weeks in almost everybody. The people that have it at 1 year say, they look good, but they say, I just don't feel as steady on my feet as I used to. The patients that I no longer will do are the people who are really horrible balance to begin with, because I have 2 patients who basically came in with a walker and horrible tremor, and they could move around, but when the thalamotomy really made their balance that much worse. They were fragile to begin with. It made them that much worse that they weren't really mobile anymore. Even though they had a steady hand, it wasn't a fair trade. So now we're doing, because of this, in the last year, we've started to do much more rigorous occupational physical therapy assessment for gait and all of their scores. We're trying to understand where's the complete, which patients really shouldn't be touched. So we've started doing that in the last year to do a more comprehensive preoperatively and postoperatively to try and understand using, all of these rating scales that the physical therapists use for gait and balance. So we're doing that on not everybody, but on patients that we think are at risk. So we'll have some data on that, some hard data on that, and may help our selection process.
Thank you.
Rees, I have a question.
Yeah.
So it seems like the technology is able to give a very precise lesion, and the complications are related to, you know, the sort of unpredictable aspect of maybe the surrounding edema related to that, or reactivity that, you know, from patient to patient is going to be slightly different. You know, so I'm wondering, other than an overt hemorrhage or something mechanical like that, to limit the complications, sort of the extension of the lesion, if you will, outside of the intended target. Have you tried to sort of pre-medicate the patient, you know, with steroids or something like that to try and minimize some of those effects? I would imagine, you know, you're doing a test lesion, you don't see these effects in the test lesion. You know, it's not something that you can really predict very well, I would imagine.
Yeah, well, and remember, this is a new technology. This is just the first 100 patients, you know. I'm doing it based upon my experience with radiofrequency and the size of a radiofrequency lesion that I would want. I think the goal would be to get tremor control with no complications whatsoever. And I think this has to do with, you have to be on target, but what's the correct volume of the lesion and extent of the lesion, right? So can we make a much smaller lesion and still get tremor control? I think that's the key, and that's what some of the imaging that we're trying to do. Right now, we're going to take these imaging characteristics that we have, look back at our complications now in this cohort to try and understand that, and then be able to proactively use that information to target maybe more accurately. Because remember, all of these cases were done with basically dead reckoning and atlas coordinates, with me adjusting it. Now, I have some experience doing this, but it wasn't based on any of those fancy images. I think if we can really refine our target, be very explicit about the extent and volume of the target, then we can, I think, minimize the complications. And I don't mind a complication as long as it's transient and mild, right? And all of the complications in these patients, except for even the hemiparesis, it's mild. I mean, you can't see it on course exam. It's, you know, a loss of fine motor activity, either in the foot tapping or, you know, the finger movement. So it's not like they're hemiparetic or hemiplegic. I mean, we're looking and testing for these things. So I think, you know, there's certainly room for improvement. But that's why I've hesitated doing the other side. You know, my experience doing it the old-fashioned way with Dr. Bertrand was, when you did the second side, there was about 1/3 of people that had cognitive problems and speech problems. So I have no interest in doing that. There are trials now going on doing the second side in a staged procedure. I've just been very cautious about it because I don't think we've refined our targeting and minimized our side effects yet on a single side to go to the second side. Because I expect that when those trials come out, there will be a much higher complication rate. And I think we need to be more advanced and experienced in doing a single side before we move to the second side.
Well, Rees, thanks very much. I see our time is up, and hopefully people will communicate directly with you if there's other questions or issues. But thanks so much for taking the time and running through this. It's a pleasure, and really, really appreciate it.
Well, pleasure seeing all my old friends and colleagues at Beth Israel.
Thanks a lot, Rees.
It's where it all started for me. Thanks, guys. Thanks, everyone.
Happy holidays.
Happy
Take care.
holidays and Merry Christmas. Yeah.
Thank you.
Good seeing you, Rees.
All right.